similar.
Scope is 180.
180.
Light source is
All right. One thing you don't notice what it's doing. It's actually okay. What did he do on the modern scopes? What does that light look like it's doing on modern scopes? It's white light. We see. What else is it doing? We see it doing what on the systems around there. What we'll use. What does that light do?
Monochromatic and polychromatic.
It looks like it's flashing. Keep it ever so simple. We're not looking for physics or anything like that. We're looking. It actually strobes through the three primary colours. Okay, very quickly. So when we look at it, it's actually white light. Older scopes work on OES, where it is just a direct light and it picks up. White balance, what it does, it shoots the white light. The chip on the end of the camera, on the end of the scope, picks up what it perceives to be the colour. It doesn't know what the colour is or what it is until it knows what it's been zeroed to, and it needs to be zeroed to white. So then when you point it at a colour or an item such as blood, it only knows it's red because it knows what white is, and it can actually then pick up the reflected light and make this processor makes an estimated guess of what the colour of the item is, what it's looking at. So it's not a true colour you see. What you see is what the processor tells you what it thinks it is. That's why the more 280s and the 260 series are all saying high definition, all this palaver. And when you first use them, you actually think, I want to go back to the old scopes because I prefer this image, because you become less occupied with that. Everything looks red, everything looks inflamed, and it does become a little bit irritating. So,
especially in bleeders, doesn't it?
Oh,
it's horrible.
Horrible. I use an optical scope on a big GI bleed because you're basically putting a torch at the area, and there's nothing strobing, there's nothing flashing back. I ain't getting purples, I ain't getting whites, I ain't getting reds. I'm just getting one colour. That's blood, that's clear lumen, that's tissue. Optical scope takes all that away, even with the adapter. So the scope needs to know what white is. This is most important. Even though this is an old system, your systems will have it. So when you go in and you think, well, that doesn't look right, has the scope been white balanced? Half the time it hasn't. But you need it white balanced before you go. What we've got here is ABC. Do you know what that is? Again, that's when you actually put it into manual mode, you can actually change the colour bands. Okay. Coming down to here, explanatory, air, and there are various levels of air: low, medium, high. I have mine on high.
You have yours on?
High.
Okay. Personally, I have it on medium.
So, but if I have a choice, I stick it on high.
I just do it because I'm not as good as Paul, so I end up putting more air. So I want it on the lower side.
It's just, I'll be honest why I don't do it. I haven't got the patience to wait. So I go, right, it's worked and I've gone. So I feel I put less air in by having it high. When I first started, and I can remember back then, I used low because I just wanted to flicker and go where I was going. And then coming down here, anybody know what that is? Sorry.
100 hertz, 300 hertz.
It's a measurement scale about the actual light itself. On the back of these processors, there's also a gauge. I don't know here that you've got one. You've got a gauge on the back of it. So on this one, what it is, just there. There's a gauge on the back. It tells you about the life, and this tells you about the light bulb life. A unit like this won't bother about the light bulb life. It'll just keep going and going and going. In the UK, we bother because when the bulb gets to 500 hours, we'll automatically change it. Here, you will just keep using it and using it and using it because you can't afford not to. And I agree with you. Ignition, we know what that is. Okay. Auto manual. Anybody know?
Lighted piston.
Brightness. Yes, you're quite right. And there is one more button somewhere. I can't see it. On here, yeah, there it is. Any idea what the other two buttons are? Transillumination. Transillumination, if you had a clear day and you were on the moon, as soon as you press the transillumination button, you should be able to see this on the moon. That's how bright that light should be. I'm not looking at the light. While that's flashing, it's in transillumination mode. The reasons why you use that, there are some people who turn around, see it? Pegs, it tells you where to put your peg. It's a good idea, but if you actually look on the internet, I wrote a paper in 1996 that says you don't need to do it. That's how far back I go. But transillumination helps you with pegs. Transillumination in colonoscopy. We tell you that there are ways of knowing you're in the cecum. What are the ways that you know you're in the cecum?
Transillumination is one.
Ooh, did I mention transillumination? That's good, keep going.
Finger poking,
Keep going.
Pendicular orifice.
Pencil.
Try radiate fold.
Cuddly toy, yes. Right, you don't remember the series, don't worry. Mercedes Benz. Okay.
Sorry.
Transillumination and finger probing. Now, if you were on my unit and you said, I'm there now, I'm going to show you tomorrow. I'm going to put this scope in to 30 centimetres tomorrow. I'm going to indent the patient's thigh. And it'll make the scope move. So, if you were with me and you says, I think I'm there, look. Every time you poke the patient, I poke you. I'm only joking. But and then the other one, which was the other one you said?
Transillumination.
Transillumination. Garbage.
We've gone a little bit ahead of what you said, because to me, if I don't see terminal island intubation, I'm sorry, I don't believe you've been to see.
Yeah.
Period.
Okay. Stay clear of.
Well, that's if you're not taking pictures and showing me the ileocecal valve as well as the pendicular orifice. So I need to see the trifid folds, I need to see the pendicular orifice, I need to see the ileocecal valve, not just a crescent. Crescent doesn't mean anything. I don't know how, but that's because the reports I get and the responsibility I have when the patient comes to see me is I've been caught many a times, and now I will not accept, period. If you've not entered terminal ileum, forget it. You need another procedure. If there is any doubt about having anything in the cecum, I will repeat the follow. I've been told that I've reached everything done. I go in and I find a polyp of about 3.5 centimeters sitting in the transverse colon. See, the guy did not even go beyond splenic flexion. And the report was complete examination, no abnormality. 3.5 centimeter polyp, you've got to be blind, in my opinion, to miss something like it. Wasn't hiding anywhere. This was not a difficult colon, it was a straight colon. So, I've learned it the hard way. Not many people take pictures here. And so, I don't know. That's how I look.
Well, I don't like transillumination for that. It's only useful for plates, in my opinion. And then it's borderline useful anyway. And then, and with regards indentation, absolutely poor tool.
The transillumination with PEG, I would not put a PEG without transillumination. It's totally opposite. If I can't transilluminate it, I don't want to put a PEG. I don't know what Paul does, but I will not. Because there is always possibility to transilluminate. It's just that we don't spend enough time. There's always this little window somewhere. You need to keep inflating and keep trying, and you will eventually make the room dark. But the tendency to do a poke, I can see it. Well, what stops you thinking it's not going through the damn transverse colon? Then you put a PEG in. I don't know. I wouldn't.
Well,
except
so
for
in 1996, I wrote a paper that said not essential.
1996.
1996.
It's obsolete now.
So, well, I still believe these buttons. Now, what do these buttons mean? Okay. Shall I tell you what they mean? They mean anything you tell them. I'm serious. I am not joking. They mean anything you tell them, because each unit will have them set differently. You see the 1, 2, 4 up there, N? See them?
Yeah.
So you actually set what they are. So you can go in and you can say number 1 freezes. It's just that there is a standard that Olympus send the scopes out with. That 1 does this, 4 takes a photo, 3 is NBI, and 2 does something else. I don't know what it does, but it does something else. And how you do is set them on there. Okay, it's just that we know what to do: freeze, photo, enhancement level, and this one is actually freeable. So what we tend to do now is set that for NBI, that one for freeze. Now the next thing is, what is the best way? You've got a polyp in front of you, and it's there. What is the best way? There's the polyp. There's the polyp where his finger is. I can see the polyp. What's the best way of viewing this polyp? What's the best way of viewing this polyp? Freeze it. So now I can relax the scope and I can look at the polyp. I can then from here now make a plan of the best way of treating that polyp. All the other times I've got the scope doing this business and all the way around, so when I get somewhere that I'm happy, freeze, not happy, freeze, happy. Now I can deal with that polyp. I can now make an assessment. I can put the scope down, I can relax, and I can see the best way to tackle the polyp. Okay? Scoping is not just about getting the scope from A to B and back again. You need to be able to do a little few of the final points in between. So in taking off a polyp, you need to assess it to make sure that it's safe to do so. Anybody got any views of seeding from when if you've got a cancer in the right colon or a large polyp in the right colon? In the UK we would biopsy it and then take the scope out. Anybody else got any views on that? We've got a cancer in the right colon, and then we've got a large flat polyp in the sigmoid. How would you deal with the cancer in the right colon? Okay, you do a biopsy.
Of the both polyps and the
Okay, all right. So the biopsy comes back as low-grade tubular villus adenoma.
maybe both right, left, and left.
Well, I'm asking you, if the polyp in the sigmoid comes back as low-grade TVA and it looked endoscopically resectable at the time,
Then no need to set the tooth, we set the polyp.
we do right hemi and then we resect it endoscopically. Anybody got any different opinion?
Investments are 10% in those cases. So we need some mucosal resection and send it for closing section. If there is invasion, then we go for segmental resection.
Okay, so you go for, so in the end you still saying anything, anybody got anything else? So I passed the scope in, we've got a sigmoid, we've got a cecal cancer, SARD, so we passed the scope in, we've got a cecal cancer. I ask my friend, where is he gone? I ask my friend for the forceps. I biopsy the hell out of my cancer. I come back and I see this endoscopically but large polyp in the sigmoid. And I ask my friend for some forceps and I take further biopsies. And the polyp in the sigmoid comes back as a low-grade TVA. I thought, this is resectable endoscopically, but we've got this cancer in the cecum. So what's the plan? Your plan is to do a right hemi and then do an EMR, etc., etc. Would that be what you would say?
It's hemicolectomy is
Okay. Can I take it right back to the time when we did the test? So, I've asked my friend for the forceps, I've taken the biopsies from the cancer, I then go around and see this polyp, I ask my friend for the forceps, I then take some biopsies. Is there anything else I should be doing?
The cells from the carcinoma can be implanted into the tooth.
How do you? What are your views about seed implantation from the same forceps that you're using from the cancer? The only reason I know it's a basic skills colonoscopy course. What I'm trying to do is, you're here for 3 days. You've got experts, okay? There's this SARD's friend. He seems to have disappeared. I was going to pick on him. So you've got experts who are here, what their opinions are, how you would go about treating it. So what's your opinion about seed implantation? now with radar heads? What would you do?
Now, the ideal procedure should be total collection.
Okay. How about the ideal procedure would be to take biopsies from the cecal and take
multiple biopsies from the different sites. You can take the multiple biopsies from whole colon. And you have to look for
How about a different set of biopsy forceps?
What you're trying to get is that should you be using the same biopsy forceps for two possible cancerous lesions or not?
No.
That's the point he's making.
What I'm doing is taking it right back. So what you've got
This
to do...
polyp, that is the second polyp. Let
Yes.
me make it a little bit more interesting. You come out and you think that this is snareable. You've taken the cancer and you see this polyp in the sigma and it's a snareable. What would you do?
So take the biopsy from the cecal mass and just do the smear polyp on the polyp carrying the sigma. And then surgery can be planned accordingly as per the stroke pathology.
If I was to say to you that a cecal cancer, does it keep its cells, or does it continually shed cells throughout the colon and come out in fecal matter? And should you then take this broad-based polyp off and inadvertently put a hole in the bowel, have you then hit the patient down an area of risk? What we're asking you to do is just think a little bit more than just...
I think you're looking at things, you're looking at the risks that you're putting a patient at. You're looking at the risk of transmission if you feel there is any. You're looking at your skills. This polyp is big. I may create complications. You make this life, you're going to make the surgeon's life hell. You create something and now he has to go and do a different surgery, whereas previously you would have gone and dealt with the right colon and you would have done with the sequence tube. So I think it depends. I mean, if you're very comfortable with a small polyp and you want to take it out, I don't think anybody would disagree with doing that. But I think you have to understand. The point is to keep pondering and keep thinking and doing the best what you can. It may not be the best in the eyes of the expert, but then you have to do things that on the ground, you are the captain. Okay, the best captain is going to do that. But am I the best captain? No, I'm not. So I'm going to do the best that I can do. But you must apply your knowledge, you must think, and then act. Not just, I see something, I'm putting it on. So that's my natural instinct. You had a plan, we have two options now. We're almost 4:40. And we've almost had only about 30 minutes, 35 minutes of lunch break, but we can have that thing that you wanted to do, where you have a trainer and two of the candidates now, or we can squeeze that somewhere tomorrow. Your call.
How do you feel?
The plan was that we'll have one of you. One will be picked up by Paul and one will be picked up by me because Bakar is not here. So one would act as a trainer and the other would be the trainee. You want to do that now?
Want to do it now, or do you want to do it
Or do you want to do it tomorrow? So we've got tomorrow, I think. Tomorrow, tired? Good.
The reason being is that when you look from a trainer point of view, it makes you a little bit more thinking about what you would do yourself, and you try to slow the situation down, and also it gives us an idea how you do it. It will tell me how you would like it done back to yourself.
Paul, did you tell them about the thumb thing? Because I wasn't.
Oh yeah, we've done the thumb thing.
You did the thumb
we've
thing.
done the thing.
Great. Okay, I think you've got enough info. I hope you've learned a few.
Is there anything you want to go through, or are you happy? Is there anything that you want to cover, recap, or anything at all?
You know, what I would suggest is that if you can come up with something now, fair enough. But when you go back and just reflect on what you've seen, look at what your practice was, and if there are questions, just write them down so that you don't forget. And come back, we have 2 more days. We're there to answer in these 2 days, and we like, as we said earlier on, we'd like to maintain contact. You'll have emails of all 3 of us, and you can keep writing and keep updating us as to what you're doing, how well you're progressing, which would be very good for us. But also you can ask questions, clinical or technical, whatever. You have access to one of the best guys, so you're very lucky. I never had that. Okay, so we call it a day. Thank you.
Thank you, sir.
So, by the way, housekeeping arrangements, tomorrow we have a course dinner, okay, and it's going to be at the seaside at a restaurant called Karachi. For those who live in Karachi, which is Karachi actually, Karachi was the old name of Karachi, and this is right जहाँ पे Creek Vista apartments हैं, जहाँ पे वो अगर village से उसी road को आप जाते जाओ, जो बहुत सारे वहाँ पे restaurants हैं. This is I think the second or third last if you're going from village towards the other side. We have transport arranged for people to gather at a place and then they can be taken. Or if you feel that most of you can make it yourselves and only a few are left, then I might as well arrange a car rather than arranging a van. Karachi wale are okay to come by themselves? Huh? I've only got 2 from Lahore, and आप लोग कहाँ ठहरे हो? आप मलीर कैंप में और आप सर्विसेज में इसमें तो आप तो बिल्कुल बीच में ही हो. So we'll organize some way.